First of all, we need to always, when we look at a patient who has a complex anatomy or a complex patient, to make sure that we have the right indication for revascularization, and always evaluate revascularization versus medical therapy. We have to always study the risk versus benefit equation and have a truly informed consent. It's very important, of course, for pre-procedural planning, intra-procedural approach that has to be well studied, and especially if we're doing a complex intervention, know where to stop and know where the limits are. And of course, especially in complex patients, the problems do not stop in the cath lab. Potentially there are problems that could drag on, and new problems can result in the post-procedural care. So in assessing the indication for revascularization, it's very important, first of all, to make sure that when we want to revascularize and when we decide to revascularize vessels, that ischemia has to be well validated. So it's very important when we talk about a lesion. Let's say I'm going to do an osteal LAD lesion that's calcified, and the patient is symptomatic. Number one, I have to be sure that this lesion is ischemic. So if it's 90% in diameter stenosis, it will be. But if it's 70 or 60, it may not be. And I don't want to put a patient through a complex procedure if the lesion is not hemodynamically significant. Number two, I'd like to make sure that the symptoms are related to the lesion. So symptoms and lesion do not always go together. And of course, I want to make sure if the symptoms are stable or unstable, and how much myocardium at risk is there. If I am performing an angioplasty on an osteal right, let's say, that's a non-dominant right, it's different than performing an angioplasty on an osteal circ that's supplying a large amount of myocardium. And if the stent thrombosis in the future, or if I run into a problem in the cath lab, I'm putting the patient more at jeopardy if the myocardium at risk is large. Another thing to keep in mind is lesion chronicity. I'll give you an example. For example, in my early days when I started performing angioplasties, a vivid example is one of a large dominant circumflex artery which was osteal lesion and very calcified. In a patient who's elderly and asymptomatic, was referred just for a stress test, doesn't have any symptoms. So now we stumble on a 95% heavily calcified osteal circumflex, large artery. There is a risk doing the procedure. I went out and started explaining this to the patient. To the family, after discussing it on the table with the patient, and explaining the risks versus benefits, until one of the family members said, well, you know what, the patient was cath 10 years ago and they told us that he had a tight lesion. I said, well, this is news to me, can you bring me more information? So I took the patient off the table. The next day they were able to bring me a film from another hospital where the same lesion that I was looking at, that 90+% circumflex osteal, was present 10 years before. So obviously this chronicity without symptoms made me not put this patient at risk of performing the angioplasty. Another thing to keep in mind is obviously the cost versus benefit ratio. This is one of my, this is a picture of an artery, one of my old collections when I was younger, doing, this heroic intervention on an artery which did not need to be done. I mean, if you really look at it, what is it supplying? It's a non-dominant right. I put 5 or 6 stents in it, jailed the most important branch, which is a right ventricular branch, and made it tighter than it was before. So, and I'm sure I didn't help the lesion, I didn't help the patient, and I put the patient, you know, at risk. I mean, the patient ended up doing well, but when you look back at things like this, you know, it's not something advisable. And when we say informed consent, it has to be informed, especially when the patient has complex lesions. Anticipated risks versus benefits have to be explained to the patients clearly. I can tell you, when I moved to this part of the world, it has been a bit more difficult to be upfront with the patient, because the culture most of the time does not allow you to detail all the risks in the manner that they need to be detailed. But an effort needs to be made with the patient and the family, especially in complex situations, to make them understand the risks versus the benefits. The benefits, for example, there is a perception about benefit. If you talk about stable coronary artery disease, there was a study that pointed out to the fact that cardiologists' belief about PCI in stable CAD reflect trial results. You know, the COURAGE trial, cardiologists, they know it, and they know that, that PCI is not going to reduce mortality in patients with stable coronary artery disease. But almost 3/4 of patients thought that without PCI, they would probably have MI within 5 years, and 88% believe that PCI would reduce the risk for myocardial infarction. Now, in terms of risk stratification, there are many tools, especially when we deal with patients with multi-vessel complex disease, to help us determine the risk of bypass surgery versus the risk of angioplasty. There are the anatomic and clinical scoring tools. On the surgery side, there is the well-known STS and well-proven STS risk calculator. And you'll be surprised, even though you think you're well experienced, that if you apply the risk score, you get really more information. So I resort to that every now and then in complex patients. There is also the Euroscore 2. And for complex lesions in the cath lab, there is the well-known syntax score. The syntax score has helped us differentiate the low score versus the high score. The high syntax score make us go to surgery because the data has been clear, as you see down here. And the low syntax score make us go either way. So this has been quite helpful and quite validated. But don't forget that it's not simply the complex anatomy that's important, but the complexity of the patient is important. Whether the patient is diabetic, is there any renal issue? If I'm going to do multi-vessel angioplasty and I'm starting with a creatinine of 2, where is that going to take me? And all these things that you see on this slide. That's why all those scores progressed from anatomic to clinical, and the syntax score moved all the way to syntax 2. Syntax 2, for example, in addition to the anatomic syntax score, added several clinical parameters that are important, such as the age, the creatinine clearance, left ventricular EF, unprotected left main, peripheral vascular disease, female sex, and COPD. And you see here how you can really, for the same patient, work out the risk of bypass surgery versus angioplasty. So it's important when we study revascularization options that we weigh the in-hospital procedural risks, as we mentioned, the potential improvement in symptoms, and the quality of life and clinical status, and also talk about the long-term risks and benefits. All of these are important to balance together. Now let me turn to the question of ad hoc PCI versus staged PCI, because in typical situations, we as interventional cardiologists stumble on complex anatomy in an ad hoc manner. In other words, we're cathing the patient, we don't know the anatomy, and then we find this ostial LAD involving the distal left main, very, very tortuous right with calcification, bifurcating PDA, and should we just move ahead or do, you know, one and stage the other? In one study from the ACC and CDR that have looked at that issue, the potential advantages and disadvantages of ad hoc PCI, meaning moving ahead with angioplasty versus doing a stage procedure. So you could decide to take the patient off the table and start your intervention later, or you can do one vessel today and another vessel another day. So what's the advantage of ad hoc PCI? Patients like ad hoc PCI because it's quicker, it's, you know, less anxiety, or you're done with it, shorter hospital stay, and of course in terms of the healthcare system, reduced use of resources and possibly lower cost. And also you don't have to stick the patient twice, therefore simpler access site management. And there was the concern of clopidogrel pre-treatment in complex lesions, that you needed the platelet inhibition to be up to speed, but no more, because now with the newer platelet inhibitors, be it prasugrel or ticagrelor, you can give the medication on the table if you have to, and get up to speed within your platelet inhibition within half an hour. In terms of disadvantages, there's of course the difficulty with informed consent. How can you really inform the patient on the table when you have a complex anatomy and have a true informed consent? There is also a limited relationship typically between the interventional cardiologist and the patient, especially if that patient was referred to the interventional cardiologist for a cath. So this rapid decision making under pressure is not ideal. And of course, many a times we think about, you know, do I have 3 more cases to go today? Therefore, you know, so you kind of, logistically, you kind of make decisions that are not necessarily to the benefit of the patient. But in the United States, there is also the reimbursement issue. So from that study, here's an interesting piece of information. In a government hospital, let's say a VA hospital, where the salaries of the physician do not really, are not really proportional to the actual collections, ad hoc angioplasty is more common than private hospitals, where staging the patient is more financially beneficial. So that is something that unfortunately plays a role in the decisions. If I do it in 1 shot versus if I do it in 2 or 3 shots, you know, there is a difference in reimbursement. But we all know that there are some clear criteria that we use and to help ourselves think in terms of patients' benefit. For example, renal function is always important, and we always keep an eye on it. Accumulated contrast dose is always important, and of course the lesion complexity itself. Now, if I was to face, I'll tell you what I normally do when I face a patient on the table with complex anatomy, and I want to discuss on the table with the patient, or I want to start the discussion with the patient, I typically talk to the patient about the options of PCI versus CABG. And if the patient is still confused, I always hold in my pocket the picture of our surgeon and show it to the patient, so that to help the patient make a decision. Now, of course, if you put all kidding aside, what we always need to do when we face such situations is to use the expanded heart team approach. I feel much better if I want to do a complex stage or unstaged angioplasty if I have discussed the findings with the surgeon, and if I gave the patients the opportunity to discuss the findings with the surgeon. And if the patient decides he wants to go for angioplasty, I feel better that if anything happens, that I have not that I have not that I have followed the right process in these type of situations. Now I'll give you just two quick examples of complex anatomy. One of them is bifurcating lesions, but for the sake of time, I'll quickly tell you that there was this important study called BBC1 that randomized simple strategy, meaning one stent versus two stents in bifurcating lesions. And the bottom line is simple strategy versus complex strategy led to the following. In simple strategy, meaning putting one stent when you can versus two, you lower, based on this study, the primary endpoint, 8% versus 15%. And the systematic two-stent technique resulted in longer procedure, higher X-ray doses, and more procedural complications, and a higher rate of in-hospital and 9-month MACE. But there always may be subtypes of coronary bifurcation that nonetheless merit a systematic two-stent strategy. For example, it's very important to try to keep the main vessel as the priority, and I'll skip all of that because I think it's a bit too technical for this audience. But the main thing is to try to keep it simple and not to complicate things. Now, if we turn to another type of complex situation, such as chronic total occlusions, which has over the past 5 years, thanks to our Japanese, well, actually more than 5 years, for the past 10 years, thanks to our Japanese colleagues who have ventured into tackling chronic total occlusions that you were never dream of tackling. Yes, there is data that shows that if you are successful, procedural success in chronic total occlusion was independently predictive of mortality. This was true of another study. Successful CTO PCI was an independent predictor of lower cardiac mortality. So if you are successful, you're helping the patient, compared to if you're not successful. Of course, we don't have today a randomized trial saying, what if we don't try, leave the patient alone, versus if we try and we are successful, versus if we try and if we're not successful. This study it needs to be done, but doesn't exist. Now, of course, with CTO, there are indicators of high success versus lower success. There are many gadgets that have come on the market to help us navigate through chronic total occlusions in terms of antegrade approach or retrograde approach. But the most important thing, in my mind, when we tackle complex CTO is to know our limitations and refer complex CTOs to high volume operators. It is very important to gain experience, not do them every now and then. So every institution needs to have 1 or 2 dedicated CTO operators. So finally, I would tell you that when approaching complex patients with complex lesions, be prepared for unforeseen problems. And when you do that, you have to be surrounded with experienced staff, do proper pre-procedural planning, as I detailed for you. You should have a detailed inventory in your lab and seek help when needed. Of course, always try not to get yourself in complex situations that you cannot get out of, and always think of challenges ahead when you deal with complex lesions, and try not to attempt the impossible. Thank you very much.